I would like to now welcome our presenters, Dr. Maria Jocson, CCS HRIF Program Director, and Blia Vang, CCS Program Analyst, who will be presenting on the whole child model.
Hello everybody. So this is Dr. Jocson and Blia here. So I'm trying to move the slides. Okay, hold on. Okay, so Blia will start her presentation on the whole child model.
Hello, welcome everyone, and thank you for your questions ahead of time. So these slides that were created were based on some of the questions that were submitted earlier on. So for this slide here, the question is, what is the whole child model in relation to CCS and HRIF? So right here, this is the regular CCS the HRIF program is a part of the CCS program. And so when the whole child model started with Senate Bill 586, it is incorporating CCS services into managed care services. So with SB 586, it's requiring all the plans to include, they need to review and authorize all the services that are non-CCS versus the CCS conditions. And so because HRIF is part of the CCS program, it incorporates the HRIF program into the whole child model as well. And just for information, the source, if you guys would like, we have the CCS whole child model program numbered letter at the bottom of the slide. And if you guys should need to see it as a resource, you can just click on it and it'll link you to the source. Next slide here is, so the next slide here is, the questions for this slide are, whole child model and referrals, especially to the NTU and DME. The process is either unclear or complicated. So as you can see, local county CCS programs will continue to receive and process referrals through the medical therapy program. Medical provided, and they will also provide services in PT and OT services through the NTU. They will still provide medical therapy conferences. The only difference is if a child has is a whole child model beneficiaries and they have full scope Medi-Cal, their DME or specialized equipment will need to be reviewed and authorized by the whole child model plan. And if you have any questions about how the whole child model and the MTP kind of interact, on the bottom here, the MTP service chart, if you can go click on there, it'll show you what the whole child model plans are responsible for. And then to confirm how the DME are authorized, it's because the plans will be reviewing the service requests, it is best to follow up with the plan. Next slide is, how come all counties are not part of the whole child model plan? So in SB 586, it only specifies that the whole child model program will be implemented in coast counties or regional health authority counties. And currently, it's only in the coast counties except Ventura County. So all coast counties except Ventura County are implemented in whole child is going to be implemented via SB 586. So that's why not all counties are going to be implementing the whole child model program. And then the other question is, will all partnership counties have the same guidelines or will they vary from county to county? As we all know, CCS services vary from county to county. So, and as far as guidelines for partnership counties, I'm sure it's going to vary county to county as well, because it really depends on the county's relationship with the plans and how the plan is going to and the county are going to just kind of have conversations with one another. And so if providers are looking for guidelines for partnership counties, it's best to talk to your counties or the plans to see what the guidelines are for their specific counties. Next slide. So this is the question for this one is, we will transition in July 2019. Do we need access to submit SARs using ESAR system? So this is so service authorization requests after implementation should be sent to CalOptima for review and authorization. So providers should defer to the plans for further details. So for Orange County, if the county is, for all service requests that are received before or on June 30th, the county is responsible to review and authorize them. For all service requests received on or after July 2019, those need to be redirected to the health plans. And the health plans will be responsible to review and authorize them. There's a question of, well, what about the SARs that have been approved prior to implementation? So for continuity of care purposes, all service authorization requests approved before the transition will be valid and remain valid until the end date of the SAR or until the beneficiary has been reassessed for care. So that's the end of the questions for the whole child model HRIF.
So this is Dr. Jocson. So just really to note that the July 1, 2019 implementation for whole child model specifically pertains to Orange County. Correct. Because the whole child model, other counties or the county organized health systems who have already implemented whole child models started July 1, 2018, and others started January 1, 2019. Right. So this is like the third phase of the whole child model implementation pertaining specifically to Orange County.
Right, and thank you, Dr. Jocson. And also on the bottom of this page is the whole child model provider notice. If you click on that, it'll go into some more details that will pertain to providers. So
we will pause at this time. Are there any questions? Because Blia will be leaving after this portion of the webinar. Erica, are there any questions?
As of right now, I don't see any questions, but Dr. Susan Hintz does have a question.
Yeah, this is Susan. I just wanted to ask a clarifying question then, because, you know, I think there has been a lot of confusion over the whole child model, but from what I understand from the beginning of Blia's presentation is we should within high-risk infant follow-up consider it to be a transparent process, and that because high-risk infant follow-up is basically enveloped within the whole child model per your description, we should not feel that anything has changed. Is that true? We can still move forward with the referrals and so forth that we have in the past?
That's correct. But remember, moving forward with the whole child model, it will be the plans that will be reviewing the service requests and authorizing the service requests. But it should be a transparent transition for the HRIF program.
Okay, so then just in follow-up to that, as Dr. Jocson knows, you know, quite well, we sometimes have challenges with needing to clarify across counties certain eligibility criteria, et cetera. So will it still be the state, the CCS, our CCS partners, who will be kind of the point people if there are concerns from high-risk infant follow-up programs about receiving authorization under the high-risk infant follow-up umbrella within those groups, within those areas that are part of the whole child model?
So let me just clarify your question. Let me see if I hear it correctly. So for authorizations for whole child model bennies, are you saying that the county will be responsible for that? Is that what you're asking?
Yeah, I'm asking kind of who is the final arbiter right now within the CCS for CCS high-risk infant follow-up. If we have a concern about eligibility, or if we get pushback from some counties, that may not be consistent with what we understand the eligibility to be, we are able to kind of go up the chain and talk to Dr. Jocson or the people that she has designated to make sure that those eligibility are clarified at the county level. If we have similar issues at the managed care plan level, who will our partner in the state be, or will we have a partner in the state?
So this is Maria. So this is Dr. Jocson. So Susan, yes, I will still be the arbiter. You can still give your concerns, submit all concerns to me, and we will work with the health plans if there is an issue with the health plans. And bear in mind that there are only 21 whole child model counties, only 5 health plans, 5 managed care health plans. So the bulk of California counties are still, not whole child model.
Right. I think some of the problem for some of us is that we, of course, in the state of California may have overlapping clients. We may have clients that are actually in a whole child model county, whereas the primary high-risk infant follow-up program may not be in that county. But I think there are some other
questions. So there are a few more questions that we received.
Okay, so let me see.
I'm sorry, Susan Davis. I'm going to unmute you so you can ask your question. Susan? Susan Davis? Okay. I don't know what happened to her. Susan?
Are the questions Q&A? Oh, okay.
I don't know where she
Susan Davis? No.
Yeah, I'm gonna mute Susan right now, but there are 2 questions from Sandra.
Okay.
Sandra Lombardi, my understanding is that our referrals for CCS, MTU, in the whole child setting needs to go to the CCS county. However, that is not what we are being told. CCS counties are telling us that we need to go to HPSM or CCAH for the referral. Please explain.
So that's correct. So referrals for the CCS NTUs are the responsibilities of the CCS counties. And so, because those are services, if you're correct, I mean, it is in the whole child model allocation methodology, it explains in there that the CCS services and the CCS MTUs are still going to be the county's responsibility.
Okay, I'm going to allow Sandra Lombardi to speak because I think she has a follow-up question. Sandra?
Hello, Sandra.
Why is it?
Hi, can you hear me?
Yes, we can hear you.
Hi, thank you for your time. So I'm Sandy Lombardi-Lytle, and I coordinate the high-risk infant follow-up program at Stanford Children's. And we
Sandra, sorry, but what county are you in? What county are you referring to?
So we serve
San Mateo, right?
Yeah, so San Mateo County, Health Plan of San Mateo, and CCAH for Monterey, Santa Cruz counties.
Okay.
So the situation we're running into is when we see children in our clinic that meet criteria to be referred to the CCS medical therapy program, we've kind of been in this flux of how to go about it. So we started with sending the referral as we typically would to the CCS county that the family resides in. However, they are telling us they cannot accept those referrals, and we need to go through Health Plan San Mateo directly and CCAH directly. However, when no specific, there's no guidelines or format as to how to actually go through and make these referrals. So we're getting a delay in service for our families because we're running into all of these glitches.
So Sandra, the medical therapy program, with whole child model implementation, the medical therapy program should not be impacted at all. It doesn't, the medical therapy program still stays at the county level. And so if you feel that you have a referral for a child for the MTP program, they should be processing those beneficiary applications because they're still determining medical therapy program eligibility, and that stays at the county level.
Okay.
And that should be, if anything, that should be specified in the county allocation methodology, which is available on the CCS Whole Child Model website.
Okay, thank you for that answer. So who shall I reach out to in the instance if we're to attempt this again by going through so if it's a San Mateo County family, and if we were to call CCS San Mateo County to make a referral for MTU, the medical therapy program, and they say no, who do I have them contact? Or
you just have them send an email, to the CCS redesign inbox.
Okay, perfect.
And then you can provide a response.
Awesome. Thank you so much. I have one other really quick question, and that is, currently, prior to the whole child model, we were able to see that our SAR 06 requests for authorization for high-risk services were either authorized or denied by accessing the county database. However, with the whole child model and the health plan of San Mateo and CCAH, we're unable to find out or have confirmed whether the authorization is in place. How do you recommend us going about doing?
So when it comes to service authorizations for your program, the county is not going to know if it's been approved or not. So the best way, I know that Alliance is trying to get portals to the counties just so they can check on authorizations. So I think that might have to be a local conversation to where you have to speak to HPSM and CCAH to see if you guys can get access to their portals just to check to see if authorizations have been reviewed and approved.
Yes, thank you for that. So I have asked for that and I've been denied. So, and one of the role of the coordinator is to ensure that the SAR 06 authorization is in place before we see the client in clinic. And so I don't have an avenue to get that confirmation.
So, you know, what I can probably do is I will pass on your concern to our managed care plans just to let them know that the HRIF programs are having difficulties finding out if a SAR has been approved or not, because then it delays care. So I'll share that with the managed care plans so they can let the contract managers know.
Thank you very much. I appreciate that.
You're welcome.
Okay, thank you, Sandra.
Thank you.
Okay, so there seems to be a few more questions. In the Q&A, Susan Davis actually was able to propose her question. Have those counties that are part of WCM, have they been notified? I am unclear if we are part of this additional program.
So Susan Davis, what county are you in?
I'm gonna see if I can unmute her.
That's okay. So Blia actually has to go, but actually whole child model counties are those counties, as we have presented, who have county organized health systems. So if you have not been notified, then you are probably
San Diego. So Susan Davis, you're in San Diego County. So San Diego County is not a part of the whole child model. However, San Diego County is participating in a pilot program with Rady's Hospital. So, but they're only seeing kids, they're only case managing kids that have 4 or 5 conditions, and so it really depends on the CCS condition of the beneficiary.
Yeah, so bottom line, San Diego is currently not a whole child model county. And if you have any questions, you can actually go to the whole child model website on the CCS, the umbrella, of course, is CCS, but you can Google whole child model and everything is in there. Which counties are whole child model counties, what plans have county organized health systems, and whether they are part of whole child model. Is there anything else, Erica?
Someone had proposed if they can provide a list of the counties, but I guess that's something that could be found on the website that you just indicated.
Yes.
If yours like, we could probably
Yes.
show them on the website real quick.
Yes.
Let me just show them on the website real quick.
So Blia will show the website.
Okay, and then just to answer, I noticed someone indicated that the hyperlinks do not work on the slides.
You have to blow it up.
So for the slides, you have to be on the biggest, the presentation has to be full
It has to
blown.
be on presentation mode.
It has to be on presentation mode, and only then will the link work.
Okay, but I think what I'll end up doing is after this call, I'll just include all of the hyperlinks in the thank you emails.
Yeah.
Everyone can kind of already have that information there.
So unfortunately, Erica, we can't exit out of this.
But I can send the link.
Yes.
Yeah, Erica, I can send you the link for the whole child model website.
Perfect. Okay. All
And
right.
then any other questions after this, Erica, because I'm leaving, please just send it to Dr. Jocson and
Yes.
we'll next to help her look at those.
So
Okay.
any other further questions, you can send them to, actually our last slide will show where you can send them, to the help desk or to Erica.
Yes.
Thank you, Blia.
Thank you, Blia.
So now we're going to continue with the high-risk infant follow-up program requirements. And here I'm showing you the required team members, because we got a question as to whether such a position is required or not. So in here, I've listed the required team members for a high-risk infant follow-up clinic or program. So we have the medical director, the coordinator, the ophthalmologist, the audiologist, the social worker, and an individual who can perform the developmental assessment. And this can be either the pediatrician or the neonatologist, a pediatric nurse practitioner, clinical nurse specialist, the PTOT, or psychologist. So in the bottom here, you will see the reference. This is the HRIF numbered letter 051016, dated October 12, 2016. And I referenced the numbered letter here versus the program letter because it specifically lists down the team members. It's more spelled out here versus the program letter. But the program letter does also tell you what the required members are for a HRIF program or clinic. So there was a question as to whether a dietitian is required, and a dietitian is currently not required to be part of the HRIF core team. And also all CCS providers and of course HRIF team members must be CCS panels. And we got a question regarding whether the social worker has to be licensed. So actually you can go to a website, it's called CCS Provider Paneling. And in there, you will find all the requirements for paneling for all the components of the HRIF team. So for example, like the social worker, it says like, I'm just going to refer to what's in there. So it says like, you must be licensed, but if you're not licensed, you must have a master's degree in social work and all these other requirements that are listed. So you just have to go to that website, CCS Provider Paneling. And I can also provide that website later to Erica along with the Whole Child Model website. And there was also a question regarding whether the MD or the pediatrician or neonatologist or the nurse practitioner has to be in attendance at all the 3 standard visits. So actually, what HRIF requires is an individual to perform the comprehensive history and physical exam. So whether that be the pediatrician or the PNP or the pediatric nurse practitioner, so long as there's an individual who is able to do that at the time of the visit. And also, there must be an individual to perform the developmental assessment. So I think I moved the slide. Okay, here. So I'm still on this slide. And then with regard to caseload, there really is no definite guideline for caseload for an outpatient special care center. So across the board for CCS, we do not have guidelines for outpatient special care centers, and HRIF is considered an outpatient special care center. We leave it to the institution to actually determine that, and that I think is just like part of the way a clinic is run. But there are definite guidelines for caseloads, because I've been asked this, like for NICUs, for inpatient facilities, because that is part of the California Code of Regulations. And also there were some questions regarding wages or funding sources for an HRIF clinic, and actually CCS that's not within the purview of CCS. That's really up to the hospital or the entity that owns the clinic or that runs the clinic. And there was also a question regarding regional centers. So regional centers belong to the Department of Developmental Services, which is of course, a separate department from the Department of Healthcare Services, to which we belong. And so therefore, the requirements cannot be made the same. You know, the HRIF requirements cannot be made the same as the regional center requirements, just because they have their own requirements and they belong to the Department of Developmental Services. So I'm going to go to the next slide here regarding the services that HRIF provides. So you can see in the slide, and I'm sure you're all familiar with this. The reference, of course, as you can see in the bottom, is the program letter 011016, dated October 12, 2016. And this slide shows the components of the services that are delivered in the HRIF clinic. So hearing and ophthalmologic assessments, of course, are required. You have to follow the guidelines in the HRIF program letter. Home assessment also follow the guidelines in the HRIF program letter. This is really an environmental assessment of the home, not just a home visit. And then there were some questions regarding Bailey 4 coming out in the fall. And there is really no strict requirement regarding the use of the Bailey 4 at this time. So the HRIF Executive Committee is considering surveying HRIF programs and clinics on their plans for using the Bailey 4. And what the program letter says is, at the third and final standard visit, which usually occurs 18 to 36 months, a developmental test such as the Bailey Scales of Infant Development, third edition, must be performed. So note that the wording is a developmental test such as. So there's really, bottom line, there's no strict requirement regarding the Bailey 4. And that's still in development, since we really don't know how that will play out. So I'm going to go to the next slide. So I'll pause here a little for any questions regarding that part, because I'm going to go next to medical eligibility. Erica, are there any questions?
There are two questions. Does each specialist, this is from Brenda Rosa, does each specialist, HRIF member, social worker, audiologist, have to be present during each visit?
So that's what I was explaining. If you look at the HRIF program letter, it says that the following have to be performed, the following assessments. So depending on what needs to be performed, so you have to follow the guidelines on hearing assessment, on eye assessment. If those are required, if those are deemed to be required at that particular point in time, then that particular individual who has to perform that assessment has to be present. But the basic individual who has to be present is the one who performs the comprehensive history physical exam and the developmental assessment and the family psychosocial assessment. I think you should just go to the program letter, and if you have any further questions, you can email me, use the HRIF inbox, so HRIF@dhcs.ca.gov.
Okay, Maria, we have another question from Julie. What is the home assessment and when it has to be done? And when does it have to be done?
So I hope that you have read the HRIF program letter. So the home assessment, the purpose of that is for evaluating the family for specific needs in the home environment. So that is to determine if there are appropriate resources to assure access to services and evaluate the parent-infant interaction, the parent's understanding of infant care, development, and special needs. So actually the home assessment is planned and it shall be provided by a home health agency. So this is per the program letter. So I encourage each of you to please go to the program letter. The guidelines are there in black and white. So it says the home assessment shall be provided by a home health agency nurse, preferably experienced in evaluating the maternal infant environment and is not to be utilized to perform direct services. And if you need, so usually one home assessment is done if deemed appropriate, and if needed, additional home assessments may be deemed required beyond the first year's initial 2 allowable visits, but you have to have some medical justification for that. Does that answer your question?
It doesn't look like we have any more questions. Oh, I got one raised hand. One moment. Amelia. Okay, Amelia, propose your question. Oh, she's muted. Okay, I think it's not working. Okay, so Amelia. Okay, Amelia. We have another question from Rennie. Would a public health nurse visit count for home visit?
So let me emphasize that the home visit, it's not a home visit per se. It's so it's a home assessment. And as I just indicated, as I just verbalized, it is for the purpose of evaluating the family for specific needs in the home environment. And our program letter says it shall be provided by a home health agency nurse. So that's the answer to the question. Anything else? If you feel that you need a waiver on who shall be performing the home assessment, you can email, as I said, you can email your questions to Erica or to me at hrif@dhcs.ca.gov, and I will provide a written answer if you think you need a waiver on that requirement.
Okay.
Anything else?
I don't, no, nothing else.
Okay, so I'm going to go to the next part of, or the next section of our webinar, and the topic is program medical eligibility. So first, I'm going to tackle this congenital heart disease eligibility. So we, CCS added this in 2016, and that's why the reference here is the HRIF program letter. Well, this one is a clarification, this other program letter, but the original program letter that I referenced in the previous slide first had the congenital heart disease medical eligibility criterion added to it. So it requires admission to a NICU or directly to a PICU or CVICU or cardiovascular ICU within the neonatal period. So that's the first 28 days of life. And surgery or minimally invasive therapeutic intervention. And an example would be catheter-based balloon angioplasty during that hospitalization. So examples of patients who would not meet this eligibility criterion. The first example is an infant diagnosed with AV canal defect but never admitted to a NICU, did not meet other HRIF eligibility criteria, discharged home with outpatient follow-up, and subsequently admitted to the cardiovascular ICU at 3 months of age for surgical intervention. So this patient does not meet HRIF eligibility criteria because it's beyond the neonatal period for the intervention. The other example is the infant was diagnosed prenatally with TOF, tetralogy of Fallot, admitted briefly to a NICU for monitoring and evaluation, did not meet other HRIF eligibility criteria, discharged home, went home without intervention, so did not meet HRIF eligibility, and subsequently admitted to a CVICU at 4 months of age for surgical intervention. And again, this patient does not meet HRIF eligibility criteria because the patient was sent home from the NICU without intervention, really, and the intervention happened at 4 months of age, which is beyond the neonatal period. So other documented problems that could result in neurologic abnormalities. So these conditions are listed in the program letter, and so a baby may have history of cardiovascular instability as determined by NICU medical staff due to sepsis, congenital heart disease, PDA, NEC, and other documented conditions. So I placed that in there because there was a question, of course, which pertains to what I said in the previous slide regarding history of cardiovascular instability, as this one, as I'm showing on the slide, for CHD or congenital heart disease, because a baby with CHD becomes eligible for HRIF services only if during the neonatal period and during the stay in the NICU an intervention such as an angioplasty was done or surgical correction was done during that stay. But of course, if the baby had a history of cardiovascular instability, as listed here, shown in the slide, that baby is, of course, eligible for HRIF. And then the other bullet point here pertains to neonatal abstinence syndrome. So currently, NAS, or neonatal abstinence syndrome, is not included in the medical eligibility criteria for HRIF. And that's how it is currently, not included. And if some people were asking about this, and actually it goes back to the history of the HRIF program, which started way back in 1979, and it was really geared towards graduates from the NICU. And that's why you will see that if the birth weight was less than or equal to 1,500 grams, or the gestational age at birth was less than 32 weeks, then really there's no question that that baby in the NICU is eligible for HRIF services. And the babies who were drug exposed are usually in rooming in or well baby nursery. So, but suffice it to say that currently NAS is not included in the medical eligibility criteria, but that CCS, of course, takes feedback like this into advisement, and we are continuously looking at how the program should be, in a sense, updated or improved. So, then the next slide pertains to hypoglycemia. So here, if you notice in the bottom, there is a pending HRIF program letter on clarification of the medical eligibility criterion for hypoglycemia, and it should be coming out soon. The HRIF Executive Committee worked on this several months back. It's just that we have a new process here for our program letters, numbered letters. So it's pending currently, but should be out really soon. So as you see here in the slide, the criterion for hypoglycemia has been clarified as shown here. So it requires, of course, admission to a NICU or directly to a PICU or CVICU within the neonatal period, and intervention, which is defined as IV boluses and or IV glucose infusion, is required in an intensive care setting, specifically for the treatment of hypoglycemia for at least 48 hours. And then, of course, there are babies with a diagnosis of congenital hyperinsulinemia or other congenital endocrinopathy associated with hypoglycemia, and definitely these babies qualify for HRIF. And then it goes without saying, evidence of seizures or brain injury by neuroimaging with hypoglycemia meets medical eligibility criteria, regardless of etiology, and of course also hypoxic ischemic encephalopathy complicated by hypoglycemia meets medical eligibility. And neonatal encephalopathy alone meets eligibility. So I'm going to pause here and see if there are any questions. Erica?
I don't see any questions. Guess we can give it a few minutes. Okay, so I have one raised hand. One moment. Sandra. Okay. Sandra? Sandra? Okay, maybe she's unable to.
Hi, can you hear me?
Yes, we can hear you now.
Thank you. Sorry, I was having some techno difficulties here. Can you give me some guidelines for the bilirubin, hyperbilirubinemia?
Okay, bilirubin. I'm just checking the program letter. So everything boils down to the program letter. So for bilirubin, the program letter says it's the last criterion in the medical eligibility, HRIF, medical eligibility part, and it says other documented problems that could result in a neurologic abnormality, such as, so A, B, and letter C is bilirubin. Bilirubin at excessive levels concerning for brain injury as determined by NICU medical staff. So it's actually depending on the course of the baby. We don't put, are you looking for a level? See, we don't really put a level because that's tricky. What are you looking for, Sandra?
So, yeah, what I'm looking for is, so we've had recently some kids discharged from our NICU that have had admissions with bilirubins as high as 28, 29. They are discharged with a normal neurologic exam. However, I guess the question then becomes, do they still remain at increased risk, and should they be authorized? And most of them are getting denied. These were babies that were admitted with abnormal neuroexam, but upon discharge, they were normal. So I guess maybe those are the situations that I should just send specifically through the help desk.
Yes, or so if you note, the criteria says that could result in a neurologic abnormality. So it's really a medical determination. So I guess the authorization is done by your county, right? Are you, Sandra, of San Mateo County? Are you in San Mateo County, Sandra?
I think we lost her.
Hello?
I think we lost her. There was Lisa from UCI indicated that, you know, the child had to have exchange transfusion on the old criteria, and the old criteria, I guess, had a level. So I don't know if that helps.
Yes. So anyway, the determination is made on her county's side, you know. So depending on the county, the authorization was being made by the medical consultants in her county. But if she has a question, she can always appeal the decision, you know, resend it or send the question through the HRIF inbox.
Okay. It doesn't look like there's any more questions pertaining to the criteria.
Okay, so if there are no other questions, I'm going to go to the next section. So this pertains to HRIF reporting, coding, and billing. So there was a question regarding, like, in the standard visit form, what do we really put in other CCS clinics? So we are asking this question actually just to see whether the baby or the patient is going to other clinics. So other clinics just pertains to other special care centers that the baby goes to, for example, cardiac, neuromuscular, hem-onc, all the other clinics that the baby requires services from. And then with regard to coding, so HRIF, of course, has the SCG 06 table, which is currently being updated to include the new developmental screening codes, because we are aware definitely that there are new developmental screening codes, and they come out of Medi-Cal. So it's like 96112, 96113, but we are aware, yeah, the table is currently being updated. There's a new process ongoing here at CCS, and we are trying to update all the tables at one time so that we don't do them piecemeal. So, but meanwhile, you can add those new screening codes to the SAR you can just add services to the SAR, or you can submit it in a separate SAR and they will be paid, since they are valid screening codes put out by Medi-Cal. And also, I'm not a billing expert, so the billing, if you have any questions on billing, so please call this number. I have provided the number and the website. So CCS billing is done, of course, through Medi-Cal. Here's the information on that. Any other questions, Erica?
There's one question from Nicole. We are also getting mixed answers from partnerships for authorizing 96113 codes. Because I think the 9113 codes are the developmental screening codes.
Yeah, so that's a new code. So this is the answer here. It's like we are updating the table, and that you can add on, but okay, I understand. Partnership is a whole child model health plan. So I will notify Blia, because the answer should be as I've written here.
Okay. And then Linda Taylor, let me allow to talk. Okay, let me see. Linda, you had a question? Linda? Okay, I think there's some technical difficulties there. I'm going to mute Linda for now. There are a couple more questions coming in.
So there is, like, on the chat box again, the web link. they're saying it's not active. But as I said, Francisco, you have to really go to the presentation mode, which is the biggest size of the slide. So I will demonstrate. So for example, this one here, there is an HRIF program letter which clarifies congenital heart disease. So I'm in the biggest mode here, and if I click on it, it will open. The link will open.
Maria, part of the reason why is because I sent a PDF version of your slides.
Oh, I see.
So
okay.
I will resend out the slides as a PowerPoint presentation. Then they'll be able to click on those links.
Yes, thank you.
I didn't realize there were active links inside the presentation. So my apologies to all.
Yeah, no worries. But that's how you, oops. I think I closed the thing.
One of the questions I guess that Linda had was, if the child is denied by CCS but approved by Medi-Cal, can we see them?
What does that mean? Can she talk? If a child is for HRIF?
Yeah, one moment. Linda, can
So
you?
only, yeah.
Linda, can you talk or speak? I've unmuted you. Okay, that's not working.
So anyway, so HRIF authorizations are done by the CCS program. So you have to have an authorization for HRIF.
So yes,
in order to
say, she said yes for HRIF. So I guess they met HRIF eligibility, but they were denied by CCS, but approved by Medi-Cal. Can they still follow them?
Medi-Cal does not do. I think what you're saying, Linda, is that the child is Medi-Cal, is a medical child, but only CCS can do HRIF authorizations because HRIF is a CCS program. So you cannot see them under the umbrella of HRIF. Can she talk or?
No, she's typing because yeah, I think maybe Linda, if you can just send me a direct email with your question, and then we'll have Maria answer it that way. And then of course, like I said, we'll send these answers to everyone who participated in the call, the meeting.
Well, Lisa is saying, tell Linda to call me.
Are there any more questions for Maria? There was a question, Grace, I guess, Grace Dale, you have questions about CCS clinics. Are you asking for a list of what these CCS clinics are? So Grace Dale, how is that different when we select what specialties they are receiving?
Oh, I don't, can she clarify a question? Can you repeat the question, Erica?
So her question is about the CCS clinics question that is asked on the standard visit forms. And so I guess she wanted to know, how is that question different from the specialties that they are receiving? So like how they have the medical special. Oh, I thought she had answered. Yeah, I think that's what she's asking. The doctor said CCS clinics such as cardiac, etc.
Okay, so in the standard visit form, there is a line there that says, are there other CCS clinics that the child is going to? So this is in addition to the specialty. So for example, if the child is already going to cardiac, then you don't have to, this question pertains to others. Are there any other
So Maria, this is Susan Hintz. I think maybe what we should do is talk about this offline, because as you recall from the state level, you and others actually wanted that question not as an additional clinic visit, but rather a confirmation that the referrals that were being made had to do with CCS eligible conditions. I think that's the question that this is going to, I believe. But maybe we can discuss this offline to just clarify
Okay.
the question.
Yes.
To make sure that we know what we're talking about here.
Thank you, Susan. Anything else?
Any other questions for Maria? Okay, so I think Maria, your last slide has the thank you and then also the website.
Yes.
Yes. So if you guys have any questions, you can always direct them to our help desk ticket, help desk, and submit a ticket at cpqccherhelp.org. Those are, of course, they will be funneled through me, and I'll make sure to include Maria. Or if there's anything that Dr. Susan Hintz needs to address, I'll make sure that she gets those as well. And we just want to thank you again for, calling in and joining. I hope this is not our first and last. I'm sure we may have another follow-up meeting. I'm sure there's other questions out there, as everything starts to roll out. And if there's any updates, this will probably be the best platform for us to kind of give out, all the information that's needed or asked.
Yeah, so thank you so much, everyone, for participating. And the questions are good. So, if you have any need for clarification of anything, please do send your questions to the CPQCC.org help desk ticket, or actually, as I mentioned, there is an HRIF inbox, hrif@dhcs.ca.gov. Thank you.